Sounds good. Hi, everyone. My name is Mary Ullman. I'm a board member of our family's SCN2A Foundation, and I want to welcome everyone to our kickoff to the RX Hope Table Talks virtual series for the summer. This is our very first session, so we're very excited to bring this educational experience to our global community. During these sessions, the families and caregivers of the patients with SCN2A related disorders will be referred to as the experts, and the presenters will be the professionals. The goal of the virtual table talks is to allow experts unprecedented access to professional researchers and clinicians working diligently to find a cure for children. This is meant to be a very casual environment, and your questions and comments are encouraged as we are all here to learn from each other. To keep things running smoothly, as we all know, please keep your audio on mute and use the reactions button to raise your hand if you'd like to talk. Alternatively, you can send questions through the chat feature and one of the moderators will reward them out loud. I now have the pleasure to hand this over to Dr. Craig Press from Children's Hospital of Colorado, who will be talking about SCN2A related epilepsy in the NICU and PICU. Take it from now. Go ahead, Craig.
Thank you. I'm really excited to be here with you guys. And as much as I'd like to think of myself as an expert, I'm really just still learning as every family is different, every kid's different, and there's still obviously a lot to learn from the community. So I'm hoping to learn just as much from the families today as what I'm able to share about how we think about things. So please, I'm very informal. So if you have questions, feel free to raise your hand through Zoom and interrupt, and I can try to answer as many questions as possible. My thought today, and Dr. Demarest has joined us, also one of the other epilepsy and genetic specialists in Colorado, and a good friend of mine that will be kind of adding to the discussion. And so what we thought about for today is I'm going to go through a little bit of just how we think in general about seizures in the NICU and in kind of the PICU, or the pediatric intensive care unit for really young kids in general, and then try to focus a little bit more specifically about SCN2A and how we might get to either that diagnosis or some of the treatments that might be specific to that and some of the experience that we've had. But that's just the global overview, and that can deviate in whichever way is more helpful to everyone. So that's just our thought. So, and I have a handful of slides that I'll pull up at the very end, but I'm going to just talk for right now because I think that's way more useful most of the time than just a bunch of PowerPoints with data and arrows. So when I hear about a new young child that's either in the NICU or in our PICU because they are still young but didn't get just born, and they're having seizures, I start to think about, why are they having seizures? Most of the time, for most kids that we see in that setting, seizures are a symptom of a problem and not necessarily the primary issue that's going on. It's honestly not, most of the time, it's not even epilepsy. It's that they've had an acute brain injury. And so that's the first thing that we're trying to figure out, which is probably what a lot of families have gone through. Is the first time they went to the hospital with seizures, the question was why, and there was a lot of diagnostic workup to make sure it wasn't a lot of other things. And so that usually drives a lot of the initial workup, which is usually MRIs and some initial blood tests that look at, your blood chemistry, the electrolytes that are in your blood counts, but honestly, not much genetic testing is happening at that point. After that initial period of giving a couple medicines, and I'm going to talk a little bit about that in a second, to treat the seizures, after that MRI and the EEGs placed and blood tests are done, then the focus often is on treatment of the seizures. And a lot of times our question is this a seizure that's just one seizure that isn't stopping, or is this a bunch of different small seizures that are happening either back to back or separated by 10 minutes, an hour, 2 hours? Because that's going to change how aggressive or how we pick what medicines we're going to use. I'm sure most families have heard of almost all of the medicines that I'm going to talk about in a second, because they're the most common ones that we use for any type of seizure. But again, if you have questions, raise your hands. So a lot of times for really young kids, the first medicines that we would use to treat the seizures in that initial setting are going to be medicines like Ativan or lorazepam. Phenobarbital is probably one of the most common ones for really young kids that we'll use. And then fosphenytoin or dilantin or phenytoin is probably the other one that we use the most in that kind of initial setting of trying to figure out how do we get seizures under control. A lot of times there's not really something specific about how we pick those medicines. It's what we have access to. Keppra is another one, or levetiracetam, because those are medicines that we know in most kids are going to be pretty effective and pretty safe. And so those are often, even if we know why a kid has epilepsy or is having seizures and it's not the first time they're coming in, those may still be the same medications that we use to try to treat those seizures up front. I think what starts to get a little bit more interesting, and what I've, in the last 3 or 4 years of seeing a lot of young kids having seizures, what I've started to appreciate is that the response to those medicines may actually help us start thinking about why a kid might be having seizures or what the most likely medicines they might respond to could be. And so, once we've given Ativan or phenobarbital or fosphenytoin, I think looking to see how good of a response a patient has is one of the things that we think that we're doing well. But often, I think what gets missed is you give a dose of medicine and the seizures stop for a period of time, and then the seizures come back because that medicine has worn off, and people will feel like the seizures just came back because of whatever's going on, rather than it being because there's not enough medicine still floating around to help take care of that kid. And I think we as doctors need to think a little bit more about that response and time window to decide, was this the most effective therapy that we could have used? And should we continue using this medicine going forward for this kid, or at least something like it? And so that's a lot of kind of the first part of how we're thinking about treating seizures in that early period. The other part that we think about is what is going on with the patient and their EEG, and thinking about what does the EEG look like potentially before they got a bunch of medicine, and what does the EEG look like after giving a lot of medicine. I think part of what makes it difficult is a lot of times babies or young kids will come into the hospital and have gotten their seizures treated with a lot of medicine before they get to the hospital where they're going to get an EEG. And all of those medicines make the EEG look a little bit more confusing. They can make the baby look a lot sicker on our EEG, and can make it difficult to interpret. Is that what this child's brain looks like without any medicine, or is that just a bunch of our medicines that have made it look that way? And so when we get the opportunity to see an EEG before a lot of medicines have been given, it can actually give us some insight into why this kid's having seizures, or what category we might put them in terms of, is this something that's going to be more benign? And I use that term very loosely and more within kind of how we've defined it from a medical expert side of things, or something more severe like one of the epileptic encephalopathies. And I'm going to show a slide in a second about that. But that's a lot of what we should be thinking about, and maybe what you've heard, or what you heard when you were first in the hospital, this debate about, is this something that's going to go away, or is this something that's more severe? And often we use words like that sound very scary. Just, is this something going to go away, or severe? And it's because a lot of times we don't have a good word to describe, our concerns, or what we're worried about. So I'm going to actually pause there for a second and ask, are there questions or things that I just talked about that people would want me to talk a little bit more about in detail, or talk a little bit about SCN2A and my experience with it, and how I think about it, and some of the medicines? But I thought maybe pausing there for a minute might be useful. And feel free to come off mute.
Anyone have any questions? Not I have a couple actually. So have you encountered any presentations, any patients who have given you a suspicion that they have a severe intractable seizures versus benign? Like what is the differentiation there? Like the
Yeah,
response to meds? Is that what's considered intractable?
so there's yes and no. That's a really good question. In the long term, yes, that if you're not responding to our medicines and the seizures don't stay away, that is how we would describe a patient as either medically refractory or intractable, that we've given you in a long-term setting more than two medicines that you haven't responded to, that would define you as intractable or medically refractory epilepsy. That does get tricky because a lot of times when kids come into the hospital and they are having a lot of seizures, in that first day, you might get 3 or 4 medicines and still be having some seizures. And that is often, I think, what gets confusing, because in that first period where someone's having a lot of seizures, or maybe it's just a bad day and a kid's really sick, that's not really what we would respond to, but it's long term after we've put a kid on a maintenance medicine or medicine they're taking every day. If they don't respond to that, that's what's going to help us define medically refractory or intractable epilepsy. That's a different question though than, is this a benign, in that benign epilepsy category, or something that's going to go away in the first couple months of life versus one of the more significant epileptic encephalopathies. And I think that, and this is kind of the question that I think is in the chat right now, is are there certain patterns on the EEG that might indicate that it's a cause? I don't know that on the EEG I would say I see something that specifically told me this is going to be SCN2A in a kid. There are things that would make me more concerned about that, and I think that's what I'm going to go into a little bit right now. So if an infant, a new baby comes into the hospital, and let's say they haven't gotten any medications to treat seizures yet because we weren't sure if they were seizures, so they got put on EEG, and we're looking to say, are these seizures? One thing that would make me more worried that this is an epileptic encephalopathy than a benign neonatal or infantile seizures would be based on that pattern between the seizures that I see. So in the more benign category, I would look and see a relatively normal EEG set of features, but I might see a little bit more spikes, but not necessarily a lot more. And they're not going to look as angry or as frequent. In a kid where I'm more worried about the developmental epileptic encephalopathies, those are going to be when I see that the EEG background is what we call discontinuous, or you might hear burst suppressed, or people might say something that looks like Odahara or one of the other syndromes that we describe. And if I saw something where the EEG is really broken up and that there's a lot of periods that just really don't look normal, and I haven't given a kid a lot of medicine yet, that's what's going to make me a little bit more concerned. Because otherwise, the individual seizures that a kid's having may not help me determine, is this something more benign or more serious? If I saw multiple different seizure types, not just different locations, that might make me also concerned in general. But a lot of times the seizures themselves can actually look pretty similar between the different types of epilepsy a kid might go on to develop. If we're not talking about kids that come into the hospital and I'm trying to decide, is this medically refractory? Because that's not what I'm going to do right away. And I've given a medicine like phenobarbital. I think most kids are going to respond at least temporarily to phenobarbital, that their seizures will get better unless it's an acute set of seizures from hypoxic ischemic encephalopathy. So something traumatic happened around birth, or they had a stroke. Those are things that they might respond to the phenobarbital. They may not. A lot of times in that setting, kids will just have a lot of seizures that require a lot of medicines. If it's epilepsy though, and it's because of a genetic change that they're having the seizures, phenobarbital might work for some period of time, but I feel like in SCN2A and other epilepsies, a lot of times the response won't last quite as long as I might expect otherwise for how much medicine I gave. Phenytoin or some of these other sodium channel agents that I'm sure most of you are very familiar with, all too familiar probably, that phenytoin in particular, I think is interesting because if kids really respond to that better than maybe the other medicines that they might have gotten up until that point, I think that can be a clue that they might have one of the gain of function SCN2A mutations or one of the KCNQ2 mutations that we know are sometimes very responsive to sodium channel drugs and can be a clue that that might be what's going on, but obviously would need a lot more testing to make that determination. My camera's right in front of the chat, so give me 1 second. At what point are they defined as benign and how is that determined? And then what is the time frame we need to consider after seizures at birth? So Emily, I'm gonna try to rephrase that and make sure I'm asking the right question. It sounds like you're asking, how long after we start seeing seizures and how old does a kid need to be to say, okay, if the seizures are still happening at this point, it's probably outside of that benign category. Is that right? Because I don't want to answer the wrong question.
Yes, correct.
So I think it depends on the, one, I think our terminology is terrible because we should never call seizures like benign. They never feel that way, but we have to find a way of defining things so we can do studies on them. Same thing as, we used to use terms like catastrophic and we try not to use that language anymore. I think, most of the benign infantile epilepsy we think of, a lot of times it's somewhere between 3 and 6 months that we would expect the seizures have stopped. And if they haven't stopped at that point, we then pair that with how is a kid doing developmentally. So if a kid's doing really well developmentally and has started to hit their milestones, even if they're still having some seizures, that may make the picture a little bit more clear, but it's not always that clear at that age because motor and development is, there's not still a ton of development at that point. So it can be really still a pretty tricky picture. I don't know if Dr. Demarest wants to add anything to that.
I just typed a little blurb in the chat, but the preferred term is self-limited now as opposed to benign, because it's not that it can't cause any problems, it's that it eventually will stop and seizures will theoretically not be needed anymore. That's really the way we define it. But you ask a really good question because, well, how long does it have to go before it stops and can then fall into that category? There's a couple articles that have looked at that for SCN2A specifically, and they showed sort of an average of about 5 months is the time at which seizures stopped in those kids that had seizures stop. I wouldn't take 5 months as a hard and fast rule because that's the average, which means there's some longer and some shorter than that. And I also think we need to be a little bit careful that we're talking about bins and categories, but these things actually exist on a spectrum, and it's not nearly as clean in real life as we try to make it when we put things into buckets so we can give guidance, figure out what the right treatment is, study things, all of that, which kind of requires us to put things into bins.
Other questions at the second?
Hello, I have one question. I'm Grace from Brazil. This is my husband, Ricardo, and we have a baby called Francisco. He is now 45 days, and he has many seizures. And now we were trying to stop the seizures with 5 drugs, and he he take the diet ketogenic, it's called, I think, yes. And I would like to ask about the cannabidiol. What do you think about this kind of drug for my baby? Do you think that will work? And now he's 3 days without any kind of crisis. And we are very glad for that. We are very happy, but we don't know what's going on, what will happen with him lately. For us, it's very difficult to understand this kind of situation. And that's why we are here. And sorry for my English.
So before we continue, I want to announce a disclaimer that all the questions asked to the specialist are going to be very limited in terms of answers. Every patient is going to be very different. So the answers that they have are not going to be very specific for your baby, because they can't give medical advice legally, to every individual patient, because they're not their patients. But I think they will tell you from their experience. They'll just share in general what they've seen. So just take that into consideration. And this is for everyone in the audience. When you have questions, again, this is a disclaimer that all questions asked will be responded in a very generalized way. Okay, thank you.
Okay.
So it's a really good question. And I think I can talk a little bit specifically about cannabidiol and other medicines that are in that category. But I think part of what can be really difficult is, and again, this as families much more than we do, that the experience with epilepsy, that it's unpredictable, is scary, and that it's frustrating because it feels a lot like trial and error, that they're like, this makes sense, let's do this, it sounds like it's going to be a good plan, and then we try it and then it doesn't work, and then they're like, let's just try more, or let's try this other thing, let's add this. And that is, the first medicine or two, it might not feel that scary, or that it doesn't feel like just randomness or trial and error, but it after a couple changes and a couple medicines, it just feels like for a lot of families that we're just throwing medicines at a kid or experimenting on them. And I want to acknowledge that I think that feeling can be very scary and frustrating, and then generates this idea that maybe the doctors don't know the answer to this, and where do we go next? And I think that that's often an experience that I see for a lot of families that is really hard. And part of it is because that is actually true, that it is trial and error in many ways, that we don't know what's going to work for each individual kid, that their metabolism or how they respond to that drug, it may be very different, or that their disease, whatever it is, whether it's SCN2A or something else, may respond in a very unique way to each medicine. And it's not, unfortunately, it's not cookie cutter enough medicine that we can often just say, this is the medicine we need and this is what we have to use. And there has to be a lot of adjustments, but it doesn't make it any better or make it feel any more scientific. I think there's a saying that people in medicine and doctors will use, that medicine, it's the art of medicine, and it's not science. I think that's actually an insult to art, that we're still just learning what we're doing, and it's not really artful. There is a science to some of this, but it's still very much personalized and for that individual patient. And so I think that that's important to talk about a little bit, because when it comes to each individual medicine, some of it has to do with how much are we giving, or how each patient might respond to that, what the context is, how old a kid is, what other medicines they're on, because I think that certainly applies to how we think about medicines like cannabidiol. The way I think about cannabidiol, we have a lot of experience with it here in Colorado, both because this was one of the first places where families came to get what the term we used for a while was artisanal, the marijuana products that were made through dispensaries and not Epidiolex from pharmaceutical companies. And then now we have a lot of experience with families using Epidiolex and CBD that way. It in the grand scheme of our medicines, I think CBD and things like that can be effective, but it's not one of the most effective medicines that we have. When I think of kids that have very hard to treat seizures, I haven't seen it be the most effective of the medicines that we have. I've seen it work for many kids, but not necessarily in the same way that some of our other medicines have. And it's sometimes unpredictable depending on what it is that you're using. If it's one of the pharmaceutical grade products, then we have a little bit better idea of what side effects to anticipate or what interactions to watch for. If it's something that's not made in that way, it can be a little bit more difficult to predict. And especially like the circumstance that you're describing of being on a bunch of different medicines or having tried a bunch of different medicines, it can be even harder to predict how cannabidiol might interact with all those medicines. And that's where I think it can get a little bit trickier. And so I think those are the things that we're often considering when we either think about starting a medicine like that, or families want to discuss, starting it from a dispensary or another place out here. Those are the things that we start to consider.
Do you typically use it in the NICU setting?
We don't tend to use cannabidiol or CBD in the NICU setting. There certainly have been reports and circumstances where families have used it either here or other states where it was available, often used in an emergency type setting when it was reported. But we don't tend to start it in our NICU, partly because usually, especially if you're still in our NICU or still that young, I know, at least from my experience, separate from SCN2A in particular, that I have a lot of other medicines that I feel like are going to be more effective. And so those are the medicines I'm going to lean on just from my experience, that if I want to pick something that's going to be more likely to work, I'd probably be still working on some of those medicines in that setting, just because we're still pretty early in a kid's seizure course if we're in the NICU still.
Thank you. I hope that answered your question, Grace from Brazil.
For the moment, I have this question. Probably I will have another one, but
Okay,
for the moment, thank you.
Your English is a lot better than my Portuguese, by the way. Craig, the next question from Vicky. This might actually be a good time to show the couple of slides you have with SCN2A specific information, and then we can sort of circle back to set that question in context.
Perfect. So I will try to bring up my PowerPoint. Can you guys see that now? Okay. So this same spectrum slide is on many of the SCN2A websites or other channelopathy websites or other places. So it's taken from this journal article. And in this case, I think it was one that was referring to SCN8A, but it applies very much to a lot of the disorders that we think about. And you have a lot more talks coming up that are going to go in more detail about the genetics of SCN2A. So I'm not going to dive into that a ton. But especially in this very early age that we're talking about, most of the mutations for SCN2A that we're seeing are these gain of function missense mutations. So mutations that have changed the function of a channel and have increased its excitability in some way. And so it's overactive. And depending on how that overactivity influences the seizures and influences brain activity underneath all of that, likely tells us in the end what phenotype or how a kid is going to behave, whether they're going to have these benign or familial or self-limited infantile seizures or one of the epileptic encephalopathies. And I think that influences also response to medications. And I'm just going to try to pull up the chat. Okay, all right. I'm going to get to that in a second. So particularly with these gain of function mutations, and in the loss of function mutations, I think that that does dramatically influence what a kid is, how likely they are to respond to a sodium channel medication. And that there's a lot of kids that are also in this in-between category in terms of their age and when they present. So the very, I don't know if the right word is aggressive or excitable mutations in the gain of function category that present or show up with seizures in the first couple weeks of life are probably different than kids that develop seizures around 3 months of age and didn't have seizures earlier than that, sometimes coming in with infantile spasms is the first type of seizure that we're seeing. Those are kind of the middle category is how I think about this. So for the kids that come in with really early seizures, I think that's what my next slide is gonna, let's see. For the kids that come in with really early seizures, so in this first month or so of life, often their kids are binned into an Ohtahara-like syndrome or the EIMFS, so the migrating focal seizures. Those are often the kinds of seizures that we're seeing really early on. And as you get a little bit farther out into that 4 to 12 month category, this is like the graph that's in the bottom, you see West syndrome, which is the infantile spasms that are often developing around that time point. And I think that that's where there's this shift from a gain of function mutation that's exquisitely responsive sometimes to sodium channel medications. And then a little bit later, there's probably an intermediate type response. That's a less well-studied group than the kids that come in really early with seizures in that first 1 to 3 months of life. And I think that that may help dictate how well someone might respond to some of our medications. On the bottom right of this chart, there's a crazy graph that is how we think about some of our seizure medicines. But if you look at the top 3, and I'll see, let me actually get my little thing to draw so I can highlight what I'm talking about. So what I want you to look at is right there. Can you guys see the circle I just drew? Okay. So on the bottom here is age of onset of seizures in days. And as you get farther out from birth, this line starts to trickle down. And what it's trying to show you is that for a medicine like fosphenytoin or carbamazepine or oxcarbazepine, these are all the sodium channel drugs that we really think about as being highly effective. The response to get to seizure freedom based on when your seizure started starts to go down. And it really starts to change around 100 days, which is that 3-month mark. Now, the dots are for individual patients, and they're still all over the chart. So each kid is still different, obviously. But the likelihood that someone might respond to these medicines to become either seizure-free or have a dramatic seizure reduction starts to become a little bit less likely as you get past that 3-month mark. And that's where this concept comes from and, general experience that we have. The other drugs that are below that, zonisamide, lamotrigine, and lacosamide or Vimpat, there's just, I think part of this is some of these take a really long time to take effect, like lamotrigine. And so you have to give that really slowly. And so by the time you're using a medicine like that, you're probably already trying that in a kid that started with seizures older. Zonisamide and Vimpat are medicines we don't use as much and aren't often going to be studied as well, just because some of them are even newer medicines, but aren't necessarily affecting channels the same way as our more traditional sodium channel drugs like phenytoin, carbamazepine, and oxcarbazepine. And I'm going to erase all my very messy marks. Let's see if I can get rid of them. There we go. And so that's a little bit about how we think about the genetics. And like I said, I know you guys are going to get a lot more talks about specific genetics and probably treatment responses later. But I use this, I'm going to try to go back in my slides, because when I think about kids that are coming in with seizures, if if I can see that someone at a really young age responds exquisitely well to a sodium channel drug, I think about this table, particularly the part that's on the right, and it's really, really tiny. And so I apologize for that, but it has a list of the most common, some of the most common genetic mutations that we see, and what are the responses to that. And this is why I've started using response to sodium channel drugs as a way to say, okay, I need to start thinking about some specific mutations if a kid wasn't responding to anything else and then responded really well to one of our medications that are in this category, because it might help me start to think about each individual kid and how likely one of these mutations might be. And we know that KCNQ2, PRRT2, and SCN2A all have, in general, pretty good responses to carbamazepine and phenytoin. And so if I see that, it makes me think that's something we need to be considering more, and probably something that I need to be thinking about starting and continuing rather than just having tried a big dose of it to try to get those seizures under control. And that's partly because the kids that have sodium channel mutations are actually a lot more common than some of the things that we otherwise think about as causing hard to treat seizures in a baby, including things like pyridoxine dependent epilepsy, which is incredibly rare, but we often will talk about giving pyridoxine and keeping a kid on that. So that's why I think about using these medicines to try to look at responses. And so the experience that we have so far and what all of the research has shown is that kids that have gain of function mutations, and this is getting to one of the questions in the chat, tend to be kids with gain of function mutations tend to respond very well to sodium channel drugs, whereas loss of function mutations, that isn't necessarily the case. And often it may be the other way around, that either will be a not clear good response or might make seizures worse, but it's often something that you just have to try in that setting, because it's a less clear responsiveness in patients that have loss of function mutations. That's been what I understand, but I would also love to hear what people, I'm going to stop sharing the screen right now, what people's experiences have been and thoughts on all of the things I just talked about.
I actually do have a question about your turnaround time for genetic testing, because that would make a huge difference in terms of what you used to treat, right? Like, how long does it take for you to get that back?
That's changed a lot in the last, 2 weeks, it seems like sometimes. When I started training, if I sent an epilepsy panel, it would take, it cost around $12,000. So I had to do a lot of arguing to even get a 64 gene epilepsy panel. And it would take about 12 weeks to get that back. So that really meant that we had to be treating things empirically or just based on what our gut was or how kids were responding. And often meant that we didn't try things that we would otherwise try if we knew what their genetic mutations were. Now, depending on where you are, what you have available to you may be very different. So I can only speak to what we do in Colorado, and most of these are commercially available ways of doing genetic testing, but some of them are very new and often weren't available when 2 or 3 years ago in reality. So the epilepsy panel that we most commonly send goes to a company called Invitae, and that right now has a turnaround time of somewhere between 2 to 4 weeks, depending on how busy they are and how much things have expanded, and I think how clear a mutation might be on their testing. And so often we can get those results back within 2 weeks sometimes. But in the NICU, especially when kids come in with their first round of seizures, kids are going to be in the hospital for a while. And so we're often trying to get our answer as fast as we can. And that's where we've started to move towards rapid whole genome sequencing. So Rady in San Diego, and I think Baylor now maybe even has a fast turnaround where we can get answers back in sometimes 48 hours from when they get the DNA from a patient, if there's a clear answer. So if they look at the genes that we ask that they think to sequence at that time, and it doesn't clearly answer the question, it can take somewhere around a month to get the results back, but those are when we feel like it's going to be a negative study. If they clearly find an answer, we can sometimes get those back within 48 business hours. So if it goes out on a Friday, it may not be till Tuesday or a Wednesday that we would get them back, but I have gotten them back within 2 to 4 days sometimes from sending it. And that does dramatically change our confidence about what it is that we're treating for a specific patient, and also probably changes a little bit about if we get a specific mutation that we know is associated with either the self-limited type of epilepsies or a more significant epileptic encephalopathy, it might help us make decisions about medications, and obviously in counseling to our families about how worried we are about one thing more than the other.
Thank you.
Craig,
That's amazing. Yeah.
why don't you talk a little bit about, because I think it ties into being able to make the diagnosis quickly. Craig's actually had some really nice experiences with SCN2A and how having a diagnosis influences his dosing on medications. Because we like to think like, oh, you just give a sodium channel drug or you don't. It's not that simple. It's sort of how much do you give? How hard do you push the sodium channel drug, which influences your response potentially. And so there's a really complicated sort of interaction between the way we're treating with the drugs and that individual's, specific variant and change in physiology and things like that. And so, but I think Craig has had some nice experiences around that.
Yeah, I think, probably many of the families here have their kids may have gotten phenytoin or something like that. And phenytoin and carbamazepine are probably the two most common drugs that we think about using in young babies in the NICU for SCN2A in particular. Those are the two best studied. Phenytoin is probably the best reported, but phenytoin and carbamazepine are both really tricky drugs. They're very complicated in terms of how your body metabolizes them, especially in really young babies. It's very hard to keep the level of phenytoin and carbamazepine in the traditional therapeutic range. And so the problem is that I think often how we think about therapeutic range for almost all of the drugs that we use in epilepsy now, our therapeutic range, we traditionally think about the amount of drug that we're giving, that we'll say that this much medicine for a patient's weight is the appropriate range of drug that we can give. And we rely a lot less on actually checking blood levels for patients. And I think that's where we run into trouble sometimes, in that particularly where we know a kid's responded to a sodium channel drug, trying to keep the level up in what is therapeutic for them might be very difficult. And where I've had some success is particularly for carbamazepine, where I can get levels back a little bit faster than even oxcarbazepine, identifying when a kid is doing well on that seizure medicine, what is the level that's in their blood, and saying, okay, now I know that's what I need to target. And it may mean that I need to use 2 or 3 times, or sometimes even way higher than that, the traditional therapeutic dosing of that medicine. But if the level in their blood is still within our normal or close to normal range, I don't really care how high the dose is if the amount that's in your blood is appropriate for that patient. And we know for other genetic mutations like SCN2A, where kids tend to respond to super therapeutic dosing of phenytoin, that it may mean that because their channels are different, that they need more. And it may mean more than what we would traditionally think of as therapeutic. So often I think we need to think more about targeting an individual patient based on the levels that they need in their blood. And sometimes that may seem like very, very high levels of these medicines. And a couple of kids I've started on either 3 or 4 times the normal therapeutic range for that drug, or had to keep adjusting the medicine to keep the level that high. And sometimes even in a couple of kids, I've started a medicine like Depakote, which I would never use in a really young kid, because if I don't know their genetic mutation, because there are some genetic mutations that can respond very adversely to Depakote. But if I know why a kid has epilepsy, I'm going to be much more comfortable using Depakote. And Depakote's a great seizure medicine. And it also has this added benefit of often inhibiting the metabolism of some of the other drugs that we use. So I can use a lower dose to get to the same level. And so in a couple kids, I actually have on Depakote, partly to treat their seizures at a low dose, but also partly to try to keep their other medicines at the level that I want without them metabolizing it so quickly because they're a baby or a young kid. And so that sometimes has really influenced how I use the medicines. And it's partly defined based on the mutation that that kid has, but also having excluded a bunch of other mutations that I'm worried about that would make me say I shouldn't use some of these drugs that now I can put into my toolbox because I know why they have epilepsy. Does that make sense? I know I may have rambled and gone on two different tangents there, so I apologize.
No, that does make a lot of sense. But you know that SCN2A kiddos have like amazing livers, right? Our kiddos just metabolize so amazingly. And you just push and push and push, and their livers are like, great.
Yes, in ways that sometimes I have found very unexpectedly frustrating, that I have had to really push things. And I think the other part is, we still, as neurologists, we often will still bin our drugs this way. But I have one patient where they were responding really well to carbamazepine because their liver was way too good. I thought, well, let's try oxcarbazepine. And I'm like, it's a sister drug. Maybe it'll work just as well. And it doesn't get metabolized as fast. It can be more stable. And it did not work at all. And I think that it may have been that specific scenario, or maybe interacting with the carbamazepine that we've been trying. I don't think we know, but people will jump to saying, well, let's try oxcarbazepine because it's easier to use and isn't metabolized as quickly. And then maybe it doesn't work. And then no one goes back and says, let's try carbamazepine again and see what the levels actually were. And maybe that would have been effective. Or maybe we go back to even phenytoin and just deal with the fact that it's hard to keep the levels up and just push it and monitor closely. Because the other option is maybe for that same kid being on a bunch of medicines that might not work. And it's not necessarily less invasive or less work to have tried a medicine that makes us more uncomfortable because we have to do blood monitoring to make sure that our levels are where they need to be.
So I think it's important just to take a moment here, because SCN2A is not one thing. To make sure you guys sort of understand which group of children Dr. Press is referring to mostly here. And that's really the earliest onset and most severe end of the spectrum, where we may have to really push sodium channel drugs to higher doses and try to target that. And that's usually going to be based on some evidence that it has helped. Right. So if you give a pretty good dose of something like phenytoin and you see no response at all, that maybe isn't an individual where we would like, oh, let's really push really hard. Right. Because you might just be barking up the wrong tree because every kid's different. But if it has been helpful, but then sort of wears off, helpful and wears off, then it's sometimes you just have to play this dosing game to try to get things stable in a way that's working for that individual. And that may be not using our standard dosing approaches that we would have for these medications, if that makes sense.
That's a great point. And I think it even gets trickier when we think about, we know this is probably true for most kids with the gain of function mutations that show up the earliest. When kids come in later, either because the seizures weren't recognized and they're 2 or 3 months old, it can be hard to figure out which category you might fit into. I think if you have infantile spasms as your first set of seizures, that might make that a little bit more clear. But some of those kids that are in that middle category may still respond to some of the sodium channel drugs, but not necessarily in the same way or the same degree. And it may be even trickier to figure out for each individual kid in that middle category, where there's some response, but it may not be as dramatic as it's often in kids with that very early presentation for seizures.
So I think just to try to make sure we're actually coming back and answering everyone's questions, So Vicky, your question about what oral medication do you start with when transitioning from IV, particularly in Odahara. And Odahara is sort of the group that we're discussing here with some of the sodium channel drugs. Not every child with Odahara and SCN2A responds to a sodium channel drug. You're more likely to than sort of other presentations of SCN2A, but every child is, again, a little bit unpredictable. So what oral med you're going to transition to is really going to be dependent on what's been effective in the IV form. Many IV meds do have oral meds also, and you can keep the same medication and continue for various reasons. Dr. Press was just talking about, if you're using phenytoin, for example, it may be hard to keep the levels up in a child who's metabolizing them very quickly. And some would choose to switch to carbamazepine or another sodium channel blocker at that time. And I don't know that there's a right or wrong on that. I think it's more what's your trade-off. And I will say that if something is working well, there is a little bit of an argument to say, don't rock the boat and try to stick with it if you can make it manageable at home. Manageable may mean more frequent doses of meds and things like that are a bit of a pain. But which med is going to be the right one orally is going to be mostly influenced by what's been most helpful IV. Anything to add to that, Dr. Press?
No, I think that's exactly right. That we should try to not rock the boat and pick the thing that seems to be working as much as we can, but also trying to take into account quality of life at home with dosing, and there are probably going to be trade-offs for effectiveness in both of those things for some of these drugs, because a lot of them don't have direct IV equivalents for the sodium channel category, and so that's where it does get tricky.
I apologize if I say your name wrong, Sane. Just to be as clear as possible on answering your question, what works for both gain of functions and loss of functions, we don't have specific drugs that are necessarily going to work for both of them, but we do have general broad category seizure meds that may be helpful in either case. And that's probably non-sodium channel drugs that we're thinking about. In that case, things like Depakote or valproic acid that Dr. Press mentioned, Keppra, phenobarbital, a whole slew of other ones that maybe aren't interacting in a way that's specific to SCN2A, but are just general seizure meds that may be helpful in a particular individual with SCN2A. And then I'm actually happy to take this genetic versus clinical diagnosis. So this was actually something that I was going to jump in about earlier that I think gets really confusing. So if you go back 20 years, we had like 3 genes that we knew caused epilepsy. If you go back 10 years, we had moved all the way up to like 5 or 6, 7 genes that we knew caused epilepsy. And now, you know, we have several hundred to maybe arguably several thousand that can at least include a risk for epilepsy. So prior to a decade ago, we needed to have some way that we could categorize types of epilepsy and understand what treatments might be effective and what are prognoses and potential causes for patients. And you'll see in a lot of old literature, if you guys spend a lot of time reading old epilepsy articles, a term idiopathic, which really just meant we don't know. And that's probably referring mostly to genetic causes of epilepsy in any type of paper from older than about 15 to 20 years ago. And so that could be a whole variety of different types of genetic causes. So back then, we used to categorize things into epilepsy syndromes. And we have a whole classification system and certain features that you have to have. And it includes both the types of seizures, as well as the onset of seizures and how seizures change over the course of an individual's life. All are part of the characteristics of an epilepsy syndrome, as well as non-seizure aspects. Is there associated developmental delay? Are there movement abnormalities? Are there any other features that also seem to be important in that group of patients? In the last 10 years, we've shifted increasingly towards classifying patients based on their genetic cause. And we would have loved to have seen that all of our epilepsy syndromes lined up one-to-one with our genetic causes, and we were really good in identifying different groups of patients. That is not how it worked at all. So the vast majority of the time, we have multiple syndromes that may be caused by a single gene, or multiple genes that can cause a particular syndrome. And SCN2A demonstrates that very well. We've talked about several different types of epilepsy syndromes that are possible with SCN2A, including what we call Ohtahara syndrome, epilepsy with migrating focal seizures, West syndrome or infantile spasms. There's also reports of Lennox-Gastaut syndrome, particularly as children get older. Those are all epilepsy syndromes. And we now think of them as a syndrome that is caused by something. So all of those syndromes that I just mentioned can actually be caused by something like a stroke or not having enough oxygen get to the brain during infancy. So something that's, acquired rather than genetic. So we need to think about it in terms of both the epilepsy syndrome and the genetics. Why? Because we get information from both of those things. We've got 50 years worth of literature that tells us something about how to treat infantile spasms, how to treat Lennox-Gastaut syndrome or Ohtahara syndrome. And we shouldn't throw all of that knowledge out because we didn't understand the genetics of those conditions at that time. However, we do want to bring in our more recent knowledge about the genetics to help further guide those same sort of decisions, treatment, prognosis, and all of those things. So I do actually think that a combination of both the syndromic diagnosis and the genetic diagnosis are important. And when we see that interaction, particularly in SCN2A, that's really powerful. So we can say you have SCN2A with an Ohtahara presentation, and that would tell Dr. Press and I a whole lot about that individual, and that they're probably more likely a high gain of function sort of variant. They may respond to sodium channel drugs, they may not, and tells us also about what their prognosis is in terms of seizures in the long run, as well as development, and we can talk more about that. And we also would get a lot of information from being able to say that they have what we used to call the benign, now call self-limited infantile seizures, and what's likely to happen with that individual. So that syndromic diagnosis actually refines how we think about the genetic diagnosis in a way that can be really powerful, if that makes sense.
Someone that raised their hand, Pradeep, if you want to go ahead and ask your question.
Yeah, hi, Pradeep this side. I have a question. There was a medication that was suggested by our doctor, and I've just named it because I'm not able to pronounce it well. I had noted that, with this medicine, what I have observed is that the seizure actually increased multiple fold. So, does it make sense for, because there's a very small group and, people who would want and spread awareness to different people. Is there a restriction in giving this medicine to the kid so that the spasm or, the seizure, as we call it, it doesn't increase to a whole new level? Because, with my own child, what happened was he was having seizures once a week, and then he was put on steroid, that stopped, and all of a sudden we changed the medication, and then the count of seizures increased almost 4 to 5 times in a day, and there were occasions where it went to 8 to 9 times. And when we raised that to the doctor, it stopped after that. As soon as we reduced, that was the medicine quantity, automatically it started giving positive signs. And, on the third day itself only he started reacting positively as soon as we stopped the medicine. So if you can just put some light on that, and if, there are other peoples also who would be listening and they would get to know, whether that medicine is useful or not. And it has something to do with the sodium channel, activity. I'm not a science student. I don't have much information about it, but, this is what I understand, that it do impact inversely also. So that's my question.
No, I think that's a great question, and this gets to the point I brought up a little bit earlier, in that every kid still is different, and I think there's two things that make responses to seizure medications tricky. One is, most of the time we hope that our seizure medicines are going to make the seizures much better very quickly. Sometimes it takes a while to get to the right dose. And sometimes at the low dose of a medicine, we can also see that the seizures get worse, or that they were changing anyways before we get to a really good dose of that medicine, before it would be effective. And it can be hard to tell, is it because the medicine wasn't helping yet, or did the medicine actually make the seizures worse? And there are definitely times that our seizure medicines that we would anticipate helping, otherwise we wouldn't have started it, end up making seizures worse. And then we have to say, okay, it's time to come back off that medicine. And that's part of that individual therapy or individual medicine that we have to do. And it's sometimes very difficult to predict. I think what also is really difficult with epilepsy, especially if it's pretty hard to treat seizures, is that there are times when a kid's seizures are just going to get worse. And it doesn't mean that we changed the medicine or something else happened, but the seizures are just starting to build up again. And it may coincide with us starting a new medicine. In fact, that happens a lot. A kid's seizures are getting worse. They've come back or increased. So, a family calls their doctor. They say, okay, let's either go up on a medicine or start a new medicine. And it may be that regardless of what we started, the seizures were going to continue to get worse because that kid has hard to treat seizures. And it may not be because that new medicine was continuing to make it worse. It may just be that the seizures were going to do that. And maybe the seizures actually would have been twice as bad if we hadn't started a new medicine, but we won't really know. And so it can be hard. At the same time, I have patients that are taking a seizure medicine and they're having a lot of seizures, and the seizures get better, and I haven't changed anything. I mean, I'd love to say that's just because the medicines that we picked finally kicked in, but it's just as likely as it's the same problem when the medicines hadn't changed and the seizures got worse, that it wasn't something that changed from a medicine side, but it's either the epilepsy is unpredictable and can sometimes just start to change, or kids' brains are developing, and as it develops, their epilepsy changes in time too. And so it can be hard to separate that out, but you're right. Specifically, any given medicine might make a kid's seizures better or worse, but we usually wouldn't pick it if we thought it was going to be a high risk of making it worse. And you just have to see what their individual response is.
I would just add to that, Pradeep, because just for a little context for SCN2A, we've talked a bunch about sodium channel drugs. Both of the drugs you've talked about, carbamazepine and oxcarbamazepine, with terribly long names, are sodium channel drugs and are often thought about for treating SCN2A. They are most likely to be effective or be helpful in individuals who start having seizures at a very young age, like in the first month or in the first 3 months of life. The older the age of epilepsy onset in an SCN2A individual, we think less likely that you're going to have a good response to a sodium channel drug. And in some cases, the sodium channel drug may actually make seizures worse. Having said that, we don't really understand it that well. And there are some kids at older ages who have responded to sodium channel drugs. You're just not as likely. There's also some babies who started very early with seizures who got no help whatsoever from sodium channel drugs, or they maybe even made it worse. So there's a lot we're we still don't understand, to make it so that we can predict what's right for a particular individual before we try something. So it's a really challenging situation to say, well, should we try a sodium channel drug in my child who didn't start having seizures at a 1 month of age, but at 8 months of age? Should we do it? We can. It's less likely to be as helpful, but it might be, and it also might make things worse. So it can be really challenging to try to make those decisions. And at the end of the day, we come back to that bit of trial and error, unfortunately. But I don't want to in any way negate what you're telling us, Pradeep, which is you saw a very clear connection between trying these medications and actually having seizures get worse. And I think you did the exact right thing with your doctor to alert them to that and to discuss getting off of them. Dr. Press is trying to also make the point that sometimes it's just fluctuation and we have to try to ride things out a little bit when we try a new medication. And that's definitely true in general, but that may not be as relevant to your specific situation that you were alluding to.
Sometimes it can just be hard to tell the difference. Is it because of the medicine or because it's just a fluctuation in general? I think Jenny asked about seizure medications and how that might affect development. That's a really good question. I think it's also a challenging question to answer in general for all epilepsy. We feel like in general, the more seizures you have, separate from what your development would be without seizures, that certainly can have an impact on what your development long-term may look like, which is part of why we tend to be pretty aggressive in trying to treat seizures and make them go away as much as we can. But there are side effects of our medicines, depending on the dose that you're on and how your body responds to it. Some kids, their development or their alertness and ability to be gaining developmental skills and interacting and be able to pick up new abilities because they're either too sleepy or we've made their muscles a little bit looser because their brain's relaxed, so their muscles are relaxed and it's hard to gain development when that's going on. It can certainly impact your development. We also know that high doses of some medicines can certainly just on their own affect your ability to grow and develop. But it is often very hard to separate out the medicine effect from how severe someone's epilepsy is. That if you don't have hard to treat epilepsy, your development statistically is probably going to be on the more positive side or the better side. And if you have harder to treat epilepsy, it's more likely to be affecting your development, but you're also more likely to be on more drugs and higher doses. So that's where it can often be difficult to separate out those two things. The other part that we
don't let us do trials where we just take babies who have no seizures and put them on seizure meds for 20 years and see how their development comes out, right? That would not be ethical.
Right. Unethical, just a little.
And so I think the other part is a little bit what Dr. Demarest was talking about in terms of the clinical diagnosis and the syndromes, in that part of epilepsy, depending on what the cause is likely also an effect on your brain and development that's independent, separated from your seizures. And that we might be able to get someone's seizures under control and not on necessarily even a high dose of medications, but their development isn't going to be typical or normal, regardless of what the seizure medication or seizure frequency is. And that can be sometimes difficult to separate out. And our hope would be that if we pick the right medicine and get someone's seizures under control, the medicine doesn't affect their development and the seizures then don't affect their development, and they continue to grow and their development progresses normally. And that's not necessarily always what we see. And that's obviously our goal, but I don't know that we're right there yet. Dr. Demarest does a lot of work on this, so he can probably add to that.
I think sort of the most basic answer of the effect of meds on development is we would probably rather not have anybody on meds, right? You know, the meds are probably not good for your brain. And I have lots of families who tell me wonderfully cheeky little comments like, well, you don't have any phenobarbital deficiency in your body, right? Like, we're not replacing something that's naturally occurring in your brain that your brain needs. These are external drugs that we're giving that we would rather not give. However, the general scientific consensus is that seizures are worse than meds. And so having seizures uncontrolled is probably more deleterious to the growing brain than the medications we're using to try to control them. Often, particularly in patients who have hard to treat epilepsy, we have both. We have uncontrolled seizures and we have more meds than we would like. And we end up having to walk a tightrope a little bit and balance things. And I have many, many families, not just with SCN2A, with other types of genetic epilepsy as well, that accept a certain amount of seizures because trying to make them go away means that kids are just completely zonked on meds. And that's probably not helpful for their ability to learn and develop. And they would rather accept a few seizures and have less meds. My general goal across all types of epilepsy is I would rather be on 2 or fewer meds for seizures. Sometimes I break that rule and sometimes I'm on more. I generally try very hard not to be on 4 or 5 medications. Generally, our experience suggests that we are more likely to get side effects from the medicines and less likely to get additional seizure control benefits when you go past 2 to 3 medicines. So yeah, you know, seizure meds are probably not great for development, but they're better than having seizures more often. And so we have to balance those two and do the best we can. Minimum amount of meds to get the effect we're trying to and the maximum effect in terms of however much seizure control we can get for that individual.
I actually have a question as you're both talking about this, and it's a case scenario. So tag team it, you two. Say there's a 45-day-old baby, example, the Brazilian baby here, that comes to you for higher level care, and you want to figure out what meds work more efficiently. So this baby's on the ketogenic diet, 5 meds, still in controlled seizures. Like, what would you do stepwise in order to clean up the profile?
It's a tough question.
I picked a really easy one, just a softball. You know, I think it depends. It probably depends on the scenario of what's going on at that exact moment. If you know, I mostly do neurocritical care, so I'm mostly in the hospital taking care of kids that are in the NICU or in our ICU, often because their seizures were so bad that they needed to be there. And I can be incredibly aggressive in terms of stripping things away and saying, okay, you're in a safe place where I can change things really rapidly and make sure that we're not causing harm while we try to answer that question. So if a kid's having still a lot of seizures is in the hospital, I can say, okay, I'm going to take away, just completely stop a couple medicines at the same time, knowing I can watch you really carefully. Whereas if you're at home or you're just coming into clinic, I might be less aggressive in doing something like that. But my first question to a family is going to be, what do you think helped the most? And try to figure that out, because that's going to be the thing that I'm going to want to keep around most likely, because that experience that I don't have with that patient yet, because they're brand new to me, is going to be the most helpful in understanding it. And then I'll say, what do you think was the least helpful or was the last thing that was added? And if it's the most recent thing that was added, I might be able to take that away really quickly, or the thing that they thought was the least helpful. A good example of that is, you know, we use levetiracetam or Keppra a lot because it's really safe. It doesn't interact with a lot of things. And it's also kind of effective for a lot of stuff. And so I will often in that setting say, let's get rid of that. If you're already on a couple other medicines, that's going to balance things out. But it's also often the thing that people are least likely to take away because it isn't interacting with things. It's not causing any problems, and they'll just leave it around. And so sometimes I'll try to take away the least side effect producing thing that's also maybe not as effective, because I think it's safe to get rid of while you're on these other medicines. So my stepwise approach, if there is one, is what was the most effective, and making sure I'm adjusting that or keeping it, thinking about the least effective or safest medicines for me to take away at that moment to clean things up, and then trying to make sure that you're in a safe place to decide how fast can I do that. And that's probably the way I generally try to approach it.
Thank you for tackling that very easy question.
Yeah, and I would make a few caveats there. So you gave an example of a 45-day-old, which means we're more likely we're going to have somebody who's inpatient in the hospital.
Right.
If we're sort of in that chronic stage where I'm seeing someone who's 8 years old and they have SCN2A, it's a longer history, right? Of sort of, well, what was added? How long have you been on it? What helped? And I understand that those are unfair questions to most families, because most of the time you're like, well, they've always been on 4 meds. I don't know. Who knows what's helping, right? And I get it. It's challenging, but we kind of do the best we can with it. And sometimes you have to just try to start peeling some things off. And I think, to Pradeep's question earlier, we should also consider that sometimes medicines aren't helping, and they may actually be making things worse. And I've had patients, not just with sodium channel drugs and SCN2A, who are on 4 or 5 meds, and their seizures get better just by taking meds away. That is not that unusual. So yeah, oftentimes when it's in that situation where there's so much, we kind of take our best guess at what we think is not helping, and we try to pull it away so we can at least get to something a little bit more clean. And then we have to go in a very methodical fashion to sort of say, okay, we're going to make one change at a time. This isn't in the hospital. This is sort of more chronic care, different than Dr. Press usually is involved with. And we're going to make one change at a time. We're going to go relatively slowly with things so that we can actually see the effect of the change and ride out some of the fluctuations we're going to always see with any patient with epilepsy, to start to narrow in. When we're in that sort of more chronic phase, if we make changes very quickly, or we're doing a lot of changes, it sort of gets into an oversteering scenario with a car, where you're kind of reacting to something that hasn't taken full effect, and then you're reacting again. And it often creates a less stable situation than if we're a little bit patient and methodical about things.
It's so hard to be patient when you want to see change fast.
I fully understand that.
One thing at a time.
I think,
Go ahead.
I was going to add 2 more things really quickly to that. One was, it gets a little bit to the question that Leah asked about, is it a common practice for clinicians to research specific mutations? And I think that gets to this point too, which is, if, anytime that, we're meeting a kid that's new, I'm going to do my research. I'm going to call Dr. Demarest and ask him to look at things and help me answer that question more specifically, and say, let's revisit for a kid. Do we know something more now than when we first met them, or if this is the first time we're meeting them? Is there something we know about their genetic information that might help us answer that question about effective drugs that we might be able to either add or take away if they're on a bunch of medicine? So I would use that information in that context also. And then I think that question of, are there things that definitely made things worse, is also really important, because if there is something that they felt like made things worse or that was added recently, that would be the other part that I would take into account in terms of getting rid of a medicine. And then it's a lot about having a doctor or provider that provides really good counseling about how to deal with those ups and downs, to make sure that you have that, a family has that expectation of, this is what we're going to tolerate while we're adjusting things, so we don't overcorrect in the middle of it. And so having that discussion with your doctor or provider ahead of time while you're adjusting things is really important, so that it's documented, so that you guys have a plan. So if someone else answers the phone one night, you don't change things too dramatically, and that you've thought about it ahead of time, so that you can figure out how you're going to ride out maybe a bump in the road with more seizures as you're adjusting things.
I think the other piece to Leah's question is that different doctors have different circumstances in which they're practicing, meaning the amount of time that they can devote to any one patient could be wildly variant across different practice situations. That's not speaking to whether they're a good doctor or a bad doctor necessarily. It's just reality of life. I think it is becoming increasingly common that neurologists are aware there may be some sort of precision medicine for a particular variant or gene, and they're looking for those answers from the literature and from other experts. The more you're with somebody who's sort of in that life and role already and does research on those kind of things, they're going to be more into those types of things. But it doesn't mean that other doctors aren't trying to do that also. And so I think that a lot of physicians are trying to do that, but this is actually relatively new for neurologists. Like we haven't, you know, again, the last decade has been an explosion of genetic etiologies. And so it has not historically always been baked into the way we're trained to think about this and to know the resources to do that. There's a lot that neurologists are learning on the fly as well as the practice of medicine evolves. And the one other caveat there is we can look at the variant and we can look at a specific change that has already been looked at in the lab, and we know exactly what the effect of that variant is, and it may not have the same impact in two different individuals. And there's been studies of SCN2A specifically where siblings both have the same change and have very different types of epilepsy. So it's more than just that one change. It probably is also influenced by other genes that you have that can either help compensate or make things worse that we don't understand very well. And so even if we do take the time and look up the variant level information, that may not provide us all the answers. And I think Pradeep has had his hand up for a little bit.
Yes, hi. Thank you for answering that last question. I have one more. Does heterozygous, I think that's the gene, you know, the mutation that you have different impact on a baby than homozygous? If you can clarify, because you know, while we got the DNA report for our baby, right, it was said that it was heterozygous, and during one of the meeting with the doctor, he said that, you know, you have two sets of genes, and if one, you know, there's a mutation in one, the other can to some extent, you know, control the gap that the one created. So if a baby have that, you know, this condition that I just said, not able to pronounce the name correctly though. So you know, what are your views? You know, does it impact, and you know, what is the kind of life a baby can have? You know, if the seizure stops, say, for 6 months and then gradually for a year, and also if you know, is there any possibility that with age, you know, the seizure also stops? You know, say 5 years. You know, because that's what I heard in one of the meeting with the doctor, that, you know, say after this particular year, you know, it will gradually come down. So if you can just help me answer these questions, you know, I've followed up one upon another. If you can just answer those, and it will be great and thankful. I'll be thankful to you.
Yeah, absolutely. And I think this will also tie into Grace's question as well in the chat. So there's a couple pieces that we think about here. And we've talked a number of times with SCN2A about how there are different buckets or bins that a particular individual might fall into. And there's pretty good reports in the literature of individuals who fall into that quote unquote benign or self-limited category. So this is a child who may have seizures that start pretty early, but usually are pretty easily controlled. 1 or 2 medicines help to control their seizures typically. And within the first few months, and I mentioned earlier, average being about 5 months, the seizures are fully controlled and stop. Now they might stay on meds for longer. They might be on meds even for a year, 2 years, 3 years. but not having seizures most of that time. So the seizures get controlled relatively quickly and are easier to control. Those groups of patients have been reported into literature to almost always have normal developmental outcomes. They do really pretty well. And those types of seizures actually can run in families. So we'll often, in our history, ask about whether parents ever had seizures and that sort of thing. And if their parents also had seizures when they were a baby, but they stopped and they grew out of it and went on and almost forgot about it because it hadn't continued to affect their life, then that's going to help reassure us that that's an individual who's going to fall into that benign / self-limited category. Outside of that, we know that SCN2A almost always has some developmental impact. So the vast majority of individuals with SCN2A who don't fall into that benign category are going to have some degree of developmental delay, and that can translate to sort of moderate side to pretty severe. And I think a lot of you within the community know what that means. And obviously, if you have developmental delay, that's going to translate into higher levels of disability as you get older. I think my job isn't to have a crystal ball and tell you this is exactly what's going to happen. I believe in always encouraging families and having hope with families. We do the best we can to control our seizures. We do therapies, because that's going to maximize that particular individual's chance of a good outcome, whatever is their potential. And we continue to move forward with it. But the reality is that the majority of patients with SCN2A related epilepsy are going to have some type of developmental challenges as they move forward. I think to the other side of your question, Pradeep, about seizures and what happens with seizures, you made a really good point. There are certainly some individuals with SCN2A whose seizures change as they get older. So even if they had really hard to control seizures as a baby, as they get to 2, 3, 4, 5 years of age, seizures may change in terms of the frequency, in terms of what they look like. And in some cases, that actually gets to better control, or longer stretches where we're not having seizures. Instead of seizures every day or several times a week, we might go for weeks at a time without having seizures. That may not be totally seizure-free, but it's a little bit, it's better. Sometimes we still get clusters of seizures that happen. So we might have periods where we're not having them for a while, and then we get a cluster we have to deal with, and then we go another period of time without them. So they can certainly change character as a child grows and develops and their brain changes. And in some cases, that's going to be to overall better, but maybe not seizure-free. That's a little less common, but can happen in some cases. And in some kids, it continues to be a real challenge that unfortunately we struggle with. And so I think there's a wide range in terms of what happens with seizures, even in individuals who had hard to control seizures early on.
Thank you for that.
Thank you so much.
I wanted to mention that a lot of our families, including myself, in the NICU setting, you know, many providers would have told us that your child is very severe, like the lifespan is 2. Usually they will tell so many families that, and just go home, love your kid, and you know, if they live past 2, that'd be a miracle. So like what typically causes them to say that for the severity of it?
We talked a little bit earlier about the difference between genetic and syndromic diagnoses.
Mm-hmm.
And some of the literature that's old literature historically for Oda-Hara syndrome and for migrating focal seizures suggest these types of dismal prognoses, where children are much more likely to have premature death in the sort of age range you were talking about. There are a lot of reasons that data is not very good data.
I was gonna say, is it like an old school type of thinking, or is that common
It's
practice?
a bad science kind of thing. I mean, just to be honest, right? Like this is what I do. I'm a clinical researcher, and we haven't always been great at clinical research. And there's things that have been sort of perpetuated in our collective knowledge that are not totally accurate and maybe not nuanced in the way that's important in this type of discussion. And so if you take that type of literature where you're going to say, oh, we're going to look at Odahara, you're defining Odahara often in a very strict way that's going to also identify the most severe of Odahara. And now we're trying to look at, oh, well, you know, we see some variation and it's not all always as severe. And by the way, our medical system 20 years ago isn't as good as it is now. We didn't have the same level of supportive care for patients to be able to help them with severe seizures, with breathing, with GI issues, with all of those kinds of things. And so I think it's not that they are making that up from nowhere, but I think there may not be a full recognition that that's probably not totally accurate or appropriate today, or in this specific individual, it doesn't represent them quite as well as they maybe are thinking that it does. And I'm with you. I hear that all the time. I have people who show up to me and tell me, you know, oh, my doctor told me this. And it's also great to prove your doctor wrong when they give you a bad prognosis. And so I don't think they're intentionally trying to hurt families or anything like that. And I think they feel a responsibility to try to be honest and straightforward about the potential prognosis. But I think there's some nuance to making those prognoses that are not always fully recognized by all the physicians, where we have some work to do to educate our own community. And I think Dr. Press will have some insight here, because he's often the one who has to give that type of news and have that conversation with people in the NICU or PICU. I just come in later after everything's settled, you know, and have more conversations.
Interesting with our scenario was that we were given an Odahara diagnosis based on EEG pattern because of this burst suppression. Later to find out that it was related to the medicine, because he was in a benzo-induced coma that caused the burst suppression. So to be given that diagnosis of Odahara and to be told that you only have 2 years without a genetic cause, without having genetic results, was just astounding, like heartbreaking, obviously. But looking back, it's like, wow, to really be that confident and say that was really, really hard.
Yeah,
we do need to have some humility as a profession. And I am very reticent usually to give concrete prognoses to families. I try to be honest about what we know, but everything has a range of outcomes, and I don't have a crystal ball. And I think anyone who tells you as though they have a crystal ball is asking to be proven wrong.
Exactly, like you can't really predict how long each child's going to live, obviously. So it's the same way, you can't predict their lifespan or when they're going to die. It's the same concept.
And I think, you know, a lot of what Scott was saying is really important for people to understand, that a lot of the data for the genetic epilepsy syndromes that were just syndromes when that data was created have not been redone, or once people have identified a genetic cause, the new paper that gets written about that is about that genetic cause, but no one's going to go back and write a paper about life expectancy in Odahara syndrome now, because it's going to include 1 billion different genetic diagnoses that have more specific information potentially. And a lot of that data is from 20 years ago. There were no NICUs, there were no PICUs 40 years ago, really, like maybe just beginning. And all of that medicine has happened since that time. And so because science and medicine have changed specifically for pediatrics so much in this time window that we have learned about epilepsy, genetics, critical care, and also just chronic care of kids at home, having access to G tubes and ventilatory support or respiratory support when you're sick are things that have kept kids alive that were developmentally not necessarily even severely affected, but needed those things to get through that critical period of infancy that dramatically have changed outcomes. And we have family associations now that are able to support families through this, that without that, many families would have likely made different decisions about the care of their child that would also affect things. And often that information, that context isn't in the papers. It's also, unfortunately, not in our teaching for our trainees and our residents as much as it needs to be. And a lot of doctors that don't do pediatric epilepsy, mostly in the NICU with a genetic specialty, and maybe also be able to read EEG, which is a very small subset of doctors, don't know how to take that information into account. And so they provide the best information they can at the time from what they know, which is flawed for lots of reasons. Even my own, I mean, even what I can tell family is flawed because I don't have perfect information. And then they provide it in a way that they think is compassionate and providing a full amount of information. But I think a lot of times once you hear the phrase, your child may not live as long as what you expected, you don't hear anything else. And maybe the next thing that they said was, but they could, but no one's listening anymore. And I talked with a family recently that I met 5 years ago in the NICU, had a traumatic injury to their baby, not a genetic thing. And I remember pretty clearly what we told them, but it is definitely not what they heard. And in the end, because they actually sent me an email 4 years later about what their kid's doing, because they remembered me saying, I want to know what your kid's doing at this age. And they wrote it not out of spite, but out of wanting to prove me wrong, which was great. I wanted to hear what they had to say. And clearly the way I had provided that information and advised them wasn't right. I think I told them the same information, but it wasn't done in the right way. So they didn't hear it in a way that they could anticipate that maybe their kid was going to do as well as they did. And that's our fault because we're not doing it right. But it's also that traumatic scenario of hearing that information that I think also makes it really difficult to be able to pull that together. Does that make sense too? Also, that
Makes sense. I mean, you said it from the beginning. Medicine. You are practicing an art, and it's not black and white. And you just basically said what you had to say based on the fact that you had in front of you, and you just deducted everything, from all the facts that you had, and came down to that one conclusion at that time. So we understand. We understand.
And I think the way I've tried to train my residents and try to have gotten better at this for myself over time is to start by saying, I'm going to tell a family, and I'll say this, I'm going to tell you what I think is the most likely. And I'm going to tell you what I think is possible. And I'm going to tell you what I think the worst case might be. So you can prepare for all of those things, but also say, I don't know where we're going to be. But I want you to prepare for what you need to prepare for, so that if the most likely course happens, you knew what to do and what to anticipate, because that's my responsibility. But to acknowledge that this is where things could end up, and remind them that we have to be humble ourselves, that we aren't perfect. And I think starting with what the most likely is, rather than often we start with the most severe, sometimes avoids that mental shutdown of hearing this terrible thing and then not being able to process the rest of the information. And I think it still makes it hard to process when you're getting prognostic information like that regardless, but trying to do it in a thoughtful way, I think we can do better.
Yeah, I love that.
I think the one thing I'd add, and I would encourage all of you, is we tend to think about this as a single conversation. And partly that's because these are hard conversations. I mean, they're hard for families, they're hard for physicians, they're uncomfortable. But we actually should not avoid them as much as we do. And it's okay to ask your physician multiple times. Now you know my child better. Now we have a year of information. Now we have 2 years of information. How does this change what you think about? How does this make you think about their prognosis in terms of seizures, in terms of development? And that's not something that we as doctors bring up as often as we should. And some of that's for good reason. We don't want to just, keep bashing you with the same sort of hard conversation, but there may be nuance to it. And I often find that the conversation I just had a year ago with the family they did not hear what I said. They heard something different. We have an opportunity to correct that and to bring a little bit more nuance to that it's not just this thing, right? And so I think we need to have those conversations over time, not just once.
And the best example of where that's critical is, family will hear that their kid might not survive till 1 or 5 or whatever age. And I haven't had this happen, but I know people that have had this happen where a kid's doing totally fine, did way better than what the family had heard or what we had expected for whatever reason. And they're like a month or 2 before that birthday, and the family shows up in the office in tears. Nothing has happened. And they are expecting that their kid may just drop dead at that age that they heard, because no one's told them any differently, that our expectations have changed. And if without bringing that conversation back to the forefront as things are changing, no one can change those expectations or has that opportunity, because one, if it's not the same doctor that had their conversation, they may not know that's what a family was told, or that's what that family's expecting. And it just highlights, like, that family should have no reason at that time to have thought that something bad was going to happen, but they were terrified, and it was influencing them in a dramatic way. And so if we don't bring that up again, or a family doesn't bring that up again, we may just address the seizures and say, see you again in 6 months. And it's not always the best medicine to do that.
That's a great point. Yeah, what do you have to say? That is so helpful. So many clinicians are too scared to discuss this with us, and we need to hear it. Thank you. So we're out of time, but we wanted to thank you both again for your very valuable time and sharing your wisdom and experience. And I know so many parents are very thankful for this. And if you have any more questions, we can always send them to them. And I think this will conclude. If you have anything else to say, or one last thought, anyone?
We appreciate all of your expertise.
Yeah.
Thank you. Thank you for listening to the other side. Right. I guess this will conclude our first session. Very good. Thank you again.
Thank you
Thanks,
so
everyone.
much. Bye-bye.
Thank you so much. Thank you.